Today I'm interviewing Dr. Charles Vacchiano, clinical professor at the Duke University School of Nursing Anesthesia Program. Dr. Vacchiano, thank you for allowing me to interview you today. Can you tell me something about your background?
Well, I spent most of my adult life in the Navy, 26 years. Most of that time as a nurse anesthetist, I went in the Navy to go to anesthesia school, and after I was there about 2 years, they sent me to anesthesia school.
After you completed your anesthesia school training, were you deployed to any type of conflict, or did you spend most of your time in the States?
I've done anesthesia in a lot of different settings. I've worked in very small hospitals where there were just two sole CRNAs, medium-sized hospitals, and then large hospitals like the National Naval Medical Center in Bethesda, which is the President's Hospital, and the Naval Medical Center in California, which is equally large. And I've spent time on 3 different deployments on board ship, and then during one of those deployments I was in the first Iraq War.
Can you tell me a little bit more about your role when you went to the first Iraq War?
Well, I was first I was on a ship that's it's a ship that's designed to deliver Marines and all their equipment to the shore, just like you see in a World War II movie when they storm the beach. And then my role on that is once those Marines, there's about 2,500 of them, once they go to the beach, then the center of that ship turns into a hospital, like a small trauma center for those Marines that go to the shore and get wounded or injured, and they get helicoptered back to the ship, and then it's like a small trauma center. And there are like 4 operating rooms on board that ship, and about a 16-bed intensive care unit, and then several hundred just sort of general beds.
Can you tell me about the practice environment, what kind of patients that you took care of?
Actually, the war was short, and we didn't have that many casualties associated with the war. Actually, we probably had just as many people that injured themselves in that evolution of loading onto those boats that go to shore and injuring themselves during the evolution of just getting there. Probably as many as we have that were actually shot or injured in another way during the war. But we did have some significant trauma. Actually, prior to that deployment, I was on a deployment where we had a young sailor that was hit in the head and had a subdural hematoma and a depressed skull fracture, and we had to actually had to take him to the operating room because that's the only ventilator we had, and he became unconscious, and his ICP was obviously going up, and so I had to put him on a ventilator and intubate him and ventilate him until we could get a neurosurgeon flown to the ship, which was sort of several hours of sitting in the operating room with him and diuresing him and hyperventilating him before we could get a neurosurgeon there. So when I was in the first Iraq War, pretty much they were the normal things that you see. By the time they got to us, we were sitting out in the Persian Gulf. By the time they got to us, if they survived, they were usually extremity wounds. Those are the most common ones: arms, legs. Rarely do you see like major chest or abdominal wounds that survive to get to the ship.
What do you think is different in terms of the current Iraq conflict? I know with all the Iraqi fatalities and as well as our military fatalities, how would you say that? How are they receiving trauma and anesthesia care?
Well, that trauma care in the military has evolved considerably even since the first Iraq War. I think there were lessons learned. There were lessons were learned there that we actually learned in the Vietnam War, but there was such a span of time between them that in typical fashion we forgot those lessons. And I think we relearned them in the first Iraq War because we weren't overwhelmed by the number of casualties, but people realized that if you can, instead of having those medical resources in the rear echelon, if you move them far forward, and even if you can just sort of scoop and run and minimum resuscitation, that there's a much better chance that those patients are going to survive, and that's what they've done now. Those resources now, there's some aboard ship, but now they're more far forward in small groups that do like on-the-spot resuscitation before they move them then to the rear echelon for more definitive care, and that's, I think, increased survivability a great deal.
Well, when you look at your practice, your membership as most often nurse anesthetists practice as members of anesthesia care teams, except in rural environments in the United States. But we know in the U.S. military that 80% of the anesthesia care is given by nurse anesthetists. Can you sort of compare or contrast your practice environment in the military versus the civilian world?
Well, like from what you said, I mean, there are, I've never in the 24 years I did anesthesia military was ever in a situation where I was supervised. There are not enough of us. There are not enough anesthesiologists to supervise all the CRNAs, and essentially we were all independent providers. You could work in any of those size hospitals and work side by side, or you could be in one room and an anesthesiologist would be in another room, everybody doing their own cases. So it's more of a collegial environment there, because it's not driven by productivity necessarily or by money, because everybody knows what everybody's making. Everybody's getting a salary that's known to the public. You don't get any more, make any more if you work independently or not independently, or if you work more hours or less hours. So it's just a different environment, and we're all independent providers. So I practiced in that setting for 24 years that I did anesthesia in the Navy. And there were some places that I was at, either small and medium hospitals, where we had no anesthesiologist. So there's obviously no collaborative or supervisory practice or team practice. Now, that's not to say we didn't work as a team, because depending on a particular case, as anybody that does anesthesia knows, sometimes it's good to have another set of hands. And that set of hands could be an anesthesiologist, or it could be another nurse anesthetist. And so we said sometimes practice in a team environment, but it was very collegial and collaborative versus a supervisory type of role.
Can you tell me, like in today, like the troops that are on the ground, I guess they're called the infantry, when there are injuries on the ground, can you tell me, and they need stabilization, can you tell me, are CRNAs on the front lines today?
Absolutely. Absolutely, they have what are called fast forward resuscitation teams, and many of those people are CRNAs. So there's more. There's been an evolution in the time that I was in the Navy. When I first came in the Navy, the only people that got deployed on board ships and that would go to those far forward areas were nurse anesthetists. And some things changed over time, and I think the anesthesiologists became aware that they needed to participate in that role of being deployed and being far forward for a lot of purpose, even for things like career advancement. And because people started taking a look, well, why do we only have nurse anesthetists out there on board these ships? Why don't we have anesthesiologists? So now there's probably a better split between the number of CRNAs and the number of anesthesiologists. But I know a number of people that are still in the military that are in Iraq and out there on the front lines.
So it's pretty safe to say if nurse anesthetists weren't quality, effective anesthesia care providers, we wouldn't be providing anesthesia care for the military or for the veterans hospital system.
I'd say that's a fair statement.
Okay, well, Dr. Vacchiano, thank you so much for taking your time to talk with me today.
You're welcome.